name is Dan Soular. I'm a family physician at Granny Tasca. I have spent almost 10 years to the day actually at Granny Tasca, started in August 2008. I'm also the Vice President of Medical Affairs, so I spent some time in administration. So I decided as a family doc, we see a lot of things in the clinic. We're kind of the jack of all trades. And one of the themes I see in clinic often is people coming in with some expectations or asking for certain services or medications without a lot of background or knowledge with that. And from my administrative role, we also occasionally get some complaints. Somebody comes to the emergency room with an earache, they're expecting to get antibiotics, and they were told they're not going to be helpful. They are not happy with that. They get sent home. And so I thought maybe today I'd go over some topics that we see frequently in clinic and from an administrative side. This is a very high level talk with a lot of different, one theme, but a lot of different topics that we'll talk about. So first of all, choosing wisely actually isn't a very clever title. It's actually the name of a campaign. It's a nationwide campaign. What I'm going to do today is to kind of introduce the campaign from a broad perspective, kind of discuss some of the reasons why the campaign started. Going to go over some select recommendations that have come out of this campaign. So a little background, as we all know, we spend a lot of money in healthcare. You can't watch the news nowadays without hearing about healthcare and cost. But one of the big problems with healthcare spending, unnecessary services, is estimated to be about $210 billion a year that we spend in the US unnecessarily. And the other one is inefficiently delivered services, $130 billion. So these are big, big numbers that we are spending that really add no value to the patient or to the country as a whole. So this number of annual waste of $765 billion came out in 2012. So you can imagine with inflation in the last 6 years, we're probably over $1 trillion on that spending. So in 2010, Dr. Brody, not to be confused with our cardiologist, Dr. Brody, published an article in the New England Journal of Medicine that really challenged US medical specialties to say, let's prove what we are recommending to our patients actually makes a difference in their lives, is cost effective, and has some science behind it. It just doesn't seem that it should be the right thing. It actually is the right thing because we've studied it. So out of this came an initiative out of the American Board of Internal Medicine Foundation, in which they named Choosing Wisely. The challenge was for all these specialty groups in the country to come up with 5 things that they do that don't make a lot of sense, either from a healthcare perspective, from a financial perspective. And it started pretty small. Started with only 9 specialty societies, so family medicine, you can read the rest. Very quickly gained widespread media coverage, and like anything, when you hit the news, you hit the Today Show or Good Morning America, other medical societies want to join in and add their 2 cents. So it's really gotten quite large. 17 additional societies have joined since 2013, so most of the major medical societies in America have joined a part of this group. This is now worldwide, 70 societies with over 1 million physicians that take part in this. So that's kind of the why we have this Choosing Wisely campaign. Now, maybe which will make a little more sense is let's go over some examples of what's come out of this. So one of the things that's the most a very common reason that I see patients is back pain. Statistics say that back pain is the 5th most common reason people come to see me, a family doc, in the clinic. So as you can imagine, if I see 20 patients a day, I'm going to see a couple of people every day with back pain, so it's a very common thing. I spend quite a bit of time every day trying to explain to people that your back pain you've had for the last week or 2 does not require any x-rays. And again, that can be disappointing to some, but really there's a couple of reasons for that. One, we know that 90 to 95% of people, no matter what we do for your back pain, you're going to be better in 6 weeks. You can take any medication we recommend, see a chiropractor, go to physical therapy. It doesn't really matter. It's going to get better for the vast, vast majority of people. And so adding an x-ray, adding the cost and the radiation of an x-ray really doesn't do you any good. And so that's one of the early findings that came out of that. And now this has become widespread enough where it doesn't take too much explanation to patients that we got to wait a while before we get an x-ray, because it really doesn't add any value. It doesn't make your back get better any quicker. So there's no real reason to do that. Of course, with this recommendation and all of them, there is always some red flags or some caveats to it. So, as physicians, we need to know what's the odd thing about your back pain that may make our antenna go up a little bit that, maybe we should do an x-ray a little sooner. So again, these are all general themes. This shouldn't be taken as specific recommendations for you or a family member. Sinusitis, not so much this time of year, but in the next couple of months, we'll start seeing a lot of people come in with runny nose and facial pain and just not feeling well. As we all know, we feel horrible with sinusitis. And this is a very challenging visit for some patients to try to explain to them why antibiotics aren't going to do any good. Part of the reason is we know by going to people's sinuses and literally taking some of that fluid out and seeing what grows in there, that over 90% of adults with sinusitis, the cause is going to be a virus. We don't have any medications that will kill viruses for this. Antibiotics kill bacteria, which are different than viruses. So because over 90% of cases will not be bacterial, antibiotics won't do anything for you. In fact, they'll probably cause harm. You're more likely to get diarrhea. You're more likely to get a rash or an allergy to amoxicillin. That's the common one. People were put on amoxicillin as a kid, they got a rash, and now they never could have amoxicillin again. And for a lot of those, amoxicillin probably was never truly indicated, and so we just gave them an allergy that they didn't come in the office looking for. Sinusitis, 16 million office visits annually. So you can imagine if 80% of these people of 16 million visits get antibiotics, that's a tremendous cost to society without any true benefit. I will give you some examples of why I think people end up with antibiotics. 15, 20 years ago, we didn't necessarily know these numbers. We didn't know that viruses caused it. So back in the 80s, 70s, early 90s, a lot of people got antibiotics. And so when they come in to see me, the young whippersnapper, Dr. So-and-so gave me antibiotics every time I had sinusitis. Why aren't you giving it to me? It's kind of a hard conversation to answer. I think that's a big part of it, is historically we always gave antibiotics because we thought we were doing the right thing, and now science says we probably aren't. We've had, quite frankly, arguments in the office. People, I will not leave until I get an antibiotic. And how do you, that's a tough conversation to have. I think some of it is our fault. I think physicians can get sloppy. It's very quick and easy to give you amoxicillin for 10 days and leave the office. It takes more work and effort for me to explain to you why this isn't necessary. So in a busy day, if people are running behind, I think some physicians might just get sloppy and give them out. I'm hoping that as this becomes more widespread, as we can get the information out to patients, that they'll start questioning, is this antibiotic really going to do me any good? Or are you just trying to make me happy with what I'm potentially looking for? So I think it's multifaceted. I can tell you we probably do a lot more harm than the few people that ever benefit from antibiotics. In fact, this is it's a little bit of a takeoff from this, but there's a lot of push now even for kids with ear infections to really hold off on antibiotics because, again, a lot of them are going to get better. And how much harm are we causing by causing diarrhea and allergies and all the other side effects and complications that can come from antibiotics. So antibiotics are a hot topic. Not to mention the fact that the more we give antibiotics, the more resistance we develop. And if you've been watching the news lately, there's bacteria that are out there living right now that we don't have an antibiotic that can kill it. And the drug companies have very little profit margin antibiotics, so there's very little research going into developing new antibiotics. So this problem is really snowballing on itself, and it's, I think this is just a tip of the iceberg. I think it's going to get worse as time goes on. The question or the comment was, doesn't customer satisfaction play a role in reimbursement? And unfortunately, I think that's one of the negative sides of having customer satisfaction, patient satisfaction play a role in this. As if you've been a patient at Gynae Task, I'm sure you've received surveys in the mail. And of course, we hope that you can fill them out positively, and we've provided good service to you and you're happy with it. But again, going back to customer service, if you came in expecting an antibiotic for your sinuses or for your ear infection, because you've always had it for the last 40 years or for whatever other reason, and I say, no, it's not indicated, it's not good for you, there's a lot, I can list all the reasons why, and you go home and say, well, that guy was a jerk, and I wasted $40 in my copay, and I didn't get what I wanted, and that comes back to us, and my rating goes down, and the government pays us less, and I think, an unintended consequence of patient satisfaction. So, it's not as complicated as, are you a good doctor or not good doctor? When I first came here, this is a side note again, but I met with my boss at the time, and we went over patient satisfaction rates, and it was about 90%, and I said, well, that's kind of what I hope to do. And he was an older doctor and kind of looked at me funny, and I said, I fully expect every day I'm going to probably disappoint a couple people that are looking for pain medications or antibiotics when it's just not indicated. I hope I'm practicing medicine well 100% of the time, but that might not equal 100% of people being happy. So, yeah, I think that plays a role in it as well. So again, $5.8 billion that we're spending on antibiotics that, could be spent on people's insulin or immunizations, things we know will definitely impact a person's life. So I challenge you guys, next time you go to the doctor and they say, I'm going to prescribe some antibiotics, ask them why. Challenge us. Make us prove it. We enjoy it, actually, because that, when the patient's engaged, that kind of increases our satisfaction in our job as well, too. So when I was going through medical school, I was rotating with a primary care doctor who was seasoned, and every patient that came in for a physical got an EKG every year. And I thought, well, that's kind of interesting. And that's one of those things he had always done because it just seemed right. We now know that, getting an EKG on somebody that has absolutely no chest pain, no heart concerns whatsoever, we know that some people will have abnormal EKGs just at their baseline. And so now if you come in and we do an EKG on you and you're feeling fine, but there's an abnormality, what do we do with that? We order another test, which leads to another test, which leads to a procedure, which has complications. And again, in the end, did we do you any good? Probably not. We probably caused some harm for you. So we know that EKGs in low-risk patients are not only non-indicated, they're kind of a waste of money and useless. So again, potential risks outweigh any benefits because as we do more and more tests, we can cause more and more problems. And once again, as long as you're not having symptoms, it doesn't improve your health outcomes. You don't live any longer because Doc X did an EKG on me from age 21 to 71. It doesn't matter. So EKGs for pre-ops. So that would be a little different. So if you're coming in for a pre-op, we weigh the risk of anesthesia and what kind of procedure you're going to go through. And oftentimes an EKG would be indicated. But if you're coming in just for your yearly physical or you needed your medication X, Y, or Z refilled, with no procedure planned, then it would not be necessary. Pap smears. So for half of our population, Pap smears used to be given when you became sexually active or when you came in for birth control. That's usually when women started getting Pap smears. It's now not necessary to do them until women turn 21, which is kind of a change. I've had a lot of teenagers come in with their moms and say, well, I had a Pap smear when I was 18, why isn't she? And so, again, the reason is younger women can have a lot of abnormalities on their Pap smear that we know your body will take care of, will clear. And so if we find an abnormality, we'll do something about it, which causes pain, stress, more procedures. And we now know that if we just kept our hands off, their body would take care of it. And all of that we used to do to women was unnecessary. Once you turn 21, of course, there's standards that you can talk to your physician about as far as routine screening. This is a common one as women age. If you had a hysterectomy for reasons that were not cancerous, so an example, if you have heavy menstrual cycles and you had your uterus removed, you do not need Pap smears anymore. That's a thing that changed as well too. Early in my career, even if you didn't have a uterus, we were still doing Pap smears. And the question is, if we're looking for cervical cancer, and we take your cervix out with your uterus, what are we looking for? So again, if anybody in here is no longer has a uterus, or anybody at home, Pap smears are no longer needed. And then once you've turned 65, if you've had negative screens, so you've had normal Pap smears in the past, and you don't have any symptoms, Pap smears aren't necessary after 65. So that usually gets me pretty high marks on the patient satisfaction surveys that go out. So this one, I see a couple times a year. So there's organizations out there that come to town they'll put advertisements in the paper saying, we're going to come and check your blood and check your blood pressure. We're going to do ultrasound of your carotids, and we're going to give you this health screen and health score. And if you are asymptomatic, looking for problems in your carotid arteries does not improve your health whatsoever. What we will do is we'll find, again, false positives. If we look hard enough, we'll find something that is there but it's not significant, it's not causing any problems. And again, the theme I'm talking about is once we find something, we're obligated to do something about it. And that something usually is more invasive procedures, which has complications, cost, stress, anxiety. And did we do any good at the end? No. So those companies don't like to hear this, but the medical opinion is steer clear of those types of screening events. There's lots of screens that are great. This one in particular is not. I still get a couple people a year that come in with this form, and they said this is going on, and so they've been living with stress and anxiety for a couple of weeks, saying, "Geez, am I going to have a stroke?" And when we do the test that should be done, we find out everything's fine, and go about your merry way. And sorry about that stress that group caused you. So if anybody's grossed out by pictures, you can close your eyes, take a nap. This is one for our pediatric population mostly. So conjunctivitis or pink eye. I work usually Fridays at the YMCA, so with the daycare we get a lot of kids that come over here because of pink eye. Pink eye is caused by three main things. Viruses, which is what that looks like. Allergies, which looks very similar to this. And bacteria. Viruses and allergies are annoying. Viruses are very contagious, but they'll get better after a couple of days if you do absolutely nothing. They can get better a little bit quicker if you wash some tap water on there to rinse the surface of the eyeball, but nothing more than that is needed. This is a completely different animal. This needs antibiotics. We get a lot of kiddos that come in with this, and their teachers, their daycare, their parents, their grandparents are very upset if they don't leave without antibiotics. And again, going back to the comment of, well, why do they get them? Well, sometimes, quite frankly, daycares won't take you back until you have antibiotics for 24 hours. And I've called the teachers, the daycare centers, and they just, quite frankly, don't care. They just want to know that they've been on antibiotics for 24 hours. Yeah, so I don't mean to throw any daycare providers under the bus. They're going off their their requirements and guidelines as well too. But I'm hopeful that those guidelines will catch up to science, because again, if I gave you antibiotic drops for that, you're going to get better in 3 days. And it's not going to have a darn thing to do about the antibiotics. So, and one thing that's helped a lot is having computers in our rooms. So when I get a kid and their parent in the room, and they're saying, "Well, I'd really like some antibiotics," I'll say, "Well, this is what requires antibiotics, this does not." And most parents say, "Oh, I see the difference." And so that's helped too. Keep it on the pediatric theme. Again, no antibiotics for viral respiratory illness. So again, kids with sinusitis, pharyngitis, sore throat. If we know it's not strep throat, which requires antibiotics, if we know strep is negative, antibiotics will not do them any good. They'll get better in 3 to 5 days, and it won't be because of the Z-Pack they were given. It'll just be because their body did all the work. Bronchitis and croup are two other viral illnesses that kids will get better on their own. Antibiotics will not help, and most certainly will harm some kids in ways we've talked about before. Cough and cold medicine should not be used for kids less than 4 years old. Part of that recommendation is we don't have a lot of studies that say it's very beneficial. We can't find a lot of parents that will sign their kids up for studies when they're 2 years old and say, "Hey, we'll give your kid cough medicine and we'll see how they turn out." So something that is, we just don't have science that proves it's helpful. Febrile seizures. So some kids, when they are sick and they get high fevers, they can have a seizure. And it's very alarming for kids. I had a nephew that went through one. It's horrible to watch your child go through a seizure. This is a pretty well-known requirement or recommendation in the emergency room. So a lot of kids that come in with their seizure, we usually make sure we find out any sign of infection, make sure their fever is controlled with Tylenol and ibuprofen, and that's it. No imaging, which is surprising to a lot of parents. My son or daughter should have a CT scan or an MRI. Why not? And again, the reason is they don't add any value. We don't see anything on there. There's radiation. For MRI, we have to sedate the child, which has its own complications or potential problems, and cost. More importantly, you should focus on the cause of the fever. So under neurology, one of the things, I do a lot of sports medicine, and so concussions has been a very common topic in the news and in sports recently. Simple concussions do not require any imaging. So again, in the old days, if you got knocked out in a football game or a hockey game, or if you slipped and fell at home and got knocked out, we rush you to the CT scan, and lo and behold, it was normal. Because concussions aren't caused by a structural problem, which is what images show us, the structure of the brain. It's caused by a metabolism problem, or how the brain is operating, and we don't see that on imaging. So again, this too, in my 10 years here, has become a little bit an easier discussion to families. Of course, with all these, there's caveats. So if there's certain things that happen during the injury, you would image them. But for the vast majority of people with head injuries, more advanced imaging is not necessary. Pulmonology. With the advent of scans, I've had people come in and say, I want a CT scan from head to toe. I want to find cancer if it's in me. And believe it or not, people come in requesting that. Not only is it harmful for you, because CT scans are a ton of radiation, it's costly to the medical system, as we saw earlier. And again, we'll find abnormalities. I'm sure if all of us had CT scans, we'd find something abnormal in all of us. But most of those abnormalities have no bearing on how long we'll live. We all have little ditzels that we find that don't have any bearing. A new recommendation to actually do something, so I know a lot of this talk is don't do this, don't do that, are for smokers. So if you are a smoker, if you've smoked in the last 15 years, it is recommended between the age of 55 and 75 to get a yearly CT scan. So that is something to choose wisely to look for lung cancer. Outside of that population of people, smokers at that age group, yearly CT scans to look for lung cancer or any other type of cancer is not recommended. Again, a lot of false positives, meaning we see something that's there, but it truly turns out to be nothing. A ton of radiation. And of course, anytime we find something abnormal, it produces a lot of anxiety for the patient and their family. So the question was musculoskeletal ultrasound, which is actually, it's a newer emerging procedure that's being done more and more on. You can do it, you can look at a rotator cuff tear. You can do a lot of different evaluations on musculoskeletal concerns using an ultrasound, which is much safer. You don't get better pictures or as much information, but oftentimes it gives you what you need. And it's also dynamic, so you can see the shoulder moving as opposed to CT scan or MRI where you're standing still. So I think it'll come. I liken it, I have some colleagues who describe it kind of as the new stethoscope. 20, 30 years from now, I think having an ultrasound in most exam rooms, I think will be normal because we're using it for more and more reasons. Gastroenterology. So I did my residency in Maplewood, Minnesota, down suburb of St. Paul. And there was a few surgeons down there who had their patients come in every 5 years for colonoscopies, even though the recommendation is 10 years. And finally I asked the patient, why are you doing this? You just had one 5 years ago. And he said, well, that doctor said he just cares about me more than other doctors. So he thinks I should do it every 5 years. And certainly there's reasons to do it more often than 10 years. By all means, there are. But if you have average risks, so let's say you have no colon cancer in your family, you're otherwise pretty healthy, your last colonoscopy showed no polyps or benign polyps, repeating again in 10 years is certainly the recommendation. And if you have one of those friendly Twin Cities surgeons that like to do it more often because they just care about you, I'd probably thank them and move on. Again, there's no additional benefit, and there's certainly an increased risk of harm. Every time we do a colonoscopy, there are potential complications. We do a lot of them nowadays, and most of them go very, very well, but just because they have become routine, there's still some potential downfalls. So these are some random, when I was putting this talk together, I was doing a stint in the hospital. We had a demented patient who was kind of on their last legs, and the family was really concerned that they weren't feeding themselves. And they had a lot of questions about feeding tubes. So we used to use a lot of feeding tubes kind of at the end of life. We know that through doing studies that feeding tubes does not extend the person's life. It certainly does not improve their quality of life. If anybody's had a feeding tube placed, it is not a pleasant procedure. And there's, again, increased complications. We're putting a rubber hose into your nose, down into your stomach, and there's lots of injury that can happen on the way down. And again, if we're not going to increase the quality or duration of life, at the end of life, this is probably not necessary. So I thought this was kind of timely to add. Maybe not anybody in here, but we do see that in the hospital from time to time. Health directives are an interesting topic. So I've found it really depends on how you frame the questions. Some folks frame it as, it kind of comes across, do you want us to do anything, or do you just want us to let you go? Or do you want to try some things? Do you want a feeding tube, but you don't want CPR? Do you want this? Do you want that? So again, I think it's a very difficult discussion to have. I try to bring it up to my patients when they're for their yearly exams, because they're in good health, they're in good spirits, they can make their decision at that point in time versus putting it on their son or daughter when their loved ones can't speak for themselves. What would mom want to do? Who knows? We see way too often a sibling in California show up that has a completely different idea of what all the siblings in Minnesota want, and now mom's spending her last days in the hospital and the kids are fighting over what, so it can turn real ugly. So, my general discussion I have with my patients when it comes to feeding tubes is, if we know you're going through a short-term issue that we have a pretty good confidence you're going to make it out of, then a feeding tube makes sense. Certain surgeries, certain procedures, there's things that can happen. Feeding tubes make absolute sense. But if we're inserting one because you're at the end of your days, you're not feeding yourself, again, science says that makes no sense. And in fact, we're probably making your life worse in your last few days. So that's usually how I kind of frame my discussion. So the question is there a difference in the impact of life between G-tubes, feeding tubes, IVs, different ways we can feed people? There's something called TPN, total parental nutrition, where we give it through the IV. And again, if we're at the end of life, then no. But again, I've had plenty of discussions with family where it's very difficult because on the other, to somebody that's not thinking that way, geez, you're starving mom. Not only is she dying, but she's starving. And it just, again, I go back to, it doesn't increase quality of life or quantity of life. So it doesn't make any sense. So the next topic, nursing home patients. This is a common call we get in the middle of the night. So Miss Jones is in the nursing home. She's 85 years old, and she just seems confused. And we took some urine from her, and it smells. Can we get an antibiotic? So this is also very difficult because oftentimes these conversations happen in the middle of the night. And do I want to argue with the nurse at 3 in the morning, or do I just want to give her antibiotics? The angel says argue for the patient, but the devil says I just want to go back to bed. So the science says, antibiotics for a patient that doesn't have any symptoms don't help for an abnormal urine. So let me put it another way. So if you're over 75 in this room and you're a female and I get a sample of urine from you and you're feeling great, there's a very good chance your urine will be abnormal, even though you're feeling fine. It has to do with anatomy and all that kind of stuff we don't have to go into. But so the problem is if we already know your urine's abnormal and now you're acting a little different and we check your urine, it's abnormal, well, is it really any different? Does that make sense? Mm-hmm. So it looks abnormal. It's easy to say, well, it's abnormal, let's give her some antibiotics. And in a week, we'll see her in the hospital with her diarrhea, her horrible nausea and vomiting. And again, I go back to feels like I'm beating a dead horse, but did we do her any good? She most likely, potentially at 85, has a little bit of dementia. And maybe at night, there's some mood changes. And the nurses should really spend more time and try to redirect and try to calm them down versus relying on antibiotics because we found an abnormal urine value. So that, again, is a common problem we have in medicine. We waste a ton of money. We probably aren't helping Miss Jones out in the middle of the night. We most certainly are causing problems because then I see them back in the hospital a week later with C. diff. And so, again, it's a challenge, and we're just as much to blame because if I don't say give her the antibiotics, she doesn't get the antibiotics. So we are kind of where the buck stops. But it's a shifting tide. I'm hoping, and again, hopefully, the next generation, Dr. Soular, doesn't have to talk about this anymore because hopefully we're better at our job. So it's kind of a widespread, all over the place type of hodgepodge questions, but you can see some big themes. Antibiotics, they're very useful in certain situations. They are not the end-all be-all. They have a ton of problems. Resistance is getting worse. We cause a lot of side effects with antibiotics, rashes, diarrhea. Some antibiotics can cause muscle and tendon tears. You name it, we can cause with antibiotics. So I guess the parting thoughts I would have is, again, choose wisely. And it's not just me choosing wisely. You know, you guys are consumers. You guys are patients. Challenge us. Doc, why are you putting me on this medication? Why are you increasing the dose? Why do you think that's a good idea? Why are you running this test? If the test is abnormal, what are you going to do about it? You know, put us on our toes. And we should be confident enough to answer those questions pretty easily. Because if I don't have that answer, I probably have no business ordering the test or ordering the therapy or ordering the medication. So it's a twofold solution, I think. You know, we need to get better at our jobs, practice medicine that science says is good and will impact people's lives. But I also put some of the challenge on patients. And again, challenge what we're doing. Because we can make mistakes, we can get sloppy, we can be tired, we can think that you're coming in expecting antibiotics and find out to realize, no, you just want to be reassured there's nothing more serious going on, and you'll be happy with that. Well, thanks for kind of joining me on this ragtag mishmash of topics. I appreciate it.